We had a great morning this morning, so hopefully we have another great evening tonight. I just want to thank everybody for coming. My name is Bobi Martinez. I'm the Catholic Mission Coordinator for AmeriCare Catholic Hospice, which is the only Catholic hospice in the Diocese of Phoenix. And we're very blessed to have a Catholic hospice here in the diocese. We don't have that everywhere around the country, and so oftentimes we have people asking where they can find a Catholic hospice somewhere else, and that isn't always possible. So tonight I'm going to touch on, before Deacon Dick talks, just a little bit about what hospice is, how Catholic hospice is a little bit different, and why picking a Catholic hospice might be something that practicing Catholics would like to consider, especially in our culture today. So what is hospice first? Let me grab my sheets here. Basically, when you ask most people what they think hospice is, they really think of hospice as a building, a place that you go. They just think of it as a general term. And actually, hospice has been developing since about the 11th century. Hospice is a philosophy of care. It really has to do with symptom management, your physical symptoms, your emotional symptoms, psychological, and at AmeriCare we also believe dealing spiritually with you at the end of your life. So hospice is a philosophy of care that different companies or agencies can execute in any number of ways. Right now, most people don't realize there's about 90 hospices in the state of Arizona alone. So there are many different companies who each will choose how they want to deliver that philosophy of care to you, which, as we keep talking a little bit, you'll understand maybe a little bit more why that would make a Catholic hospice a little bit different. So in terms of hospice care, just a little bit of background about me. My background is in pro-life work. I started about the age of 5, and I really have done things all along the spectrum of pro-life ministry, from beginning of life and to the end of life, and now really focusing a lot in my work on end of life. And I always like to try and take something out of our catechism to try and get people to really focus on and just take a minute to think about what our church tells us about respect for life. Most of the time when people look at the catechism for a life issue, they're usually thinking about beginning of life or abortion. And that's something that we just tend to do because we talk about that so much. But it's really important to look at it in terms of our whole life spectrum and the many life issues that we face. For example, these two quotes I focus on when I'm teaching a pro-life class to 7th graders every spring, and yet it's still very poignant for what we're talking about tonight. So I just wanted to read both of these with you. The first one says, human life must be respected and protected absolutely from the moment of conception. Now, if you really look at that, it's not a suggestion. It doesn't ask us to respect and protect life as Catholics. It tells us it must be. From that very moment we're conceived until we naturally die, we are called on as Catholic Christians that we must respect and protect that gift that God has given us of our lives. The second quote, human life is sacred because from its beginning it involves the creative action of God, and it remains forever in a special relationship with the Creator, who is its sole end. God alone is the Lord of life from its beginning until its end. That's the really important part. If you take something away from this, let's read that again. God alone is the Lord of life from its beginning until its end. No one can under any circumstances claim for himself the right directly to destroy an innocent human being. If we really kind of try to digest that for a second, it's very important to understand that in our society today and under our current government, that is not the idea of where we live right now. And we're seeing that increasingly be things that we have to deal with different life issues, is we are not recognizing any longer that God alone is the Lord of our lives. He decides when we begin, and He is to decide when we take our last breath. So on that note, for AmeriCare being a Catholic hospice, AmeriCare actually, a lot of people didn't know about AmeriCare before we got this decree from Bishop Olmsted, and we're coming up on our 1-year anniversary. Bishop Olmsted gave us his approval and his decree that we are an official Catholic hospice for the diocese last February. And AmeriCare is locally owned and operated by a family of 5 practicing Catholic siblings and their mother. And they have been providing hospice care here in the Valley for just about 8 years now. And so most people didn't know that they were here. And a couple of years ago, they really realized that they were, as practicing Catholics, treating their patients in some instances differently in how they were executing that hospice philosophy, and decided to contact the diocese and ask the bishop if he would consider looking at their case studies and looking how they did business, and if he would consider acknowledging them as an official Catholic hospice. And it took several months, and then he did give us his decree. And then every year we'll be meeting with the ethics board from the diocese to go over what we do for our patients, how we're separate as a Catholic hospice, how we go above and beyond, and most importantly, how we again respect that gift of God's life until its natural end. Most people, I'll go back for a second. For a Catholic hospice, we always follow the ethical and religious directives. That's what Deacon Dick will touch a lot about on when he talks in a little bit. The ERDs is what we call them. When we do admit paperwork for patients, we always have an extra sheet in there. And that is so that it tells them we are a Catholic hospice. We serve people of all faiths. We don't only take care of Catholics. Yet that piece of paper they sign that makes them aware from the very beginning that we won't do anything that would not respect that gift of their life. We would not over-medicate them. We would not hasten their death in any way. We would not be okay with any type of physician-assisted suicide or euthanasia practice, even if that is what that family said that they wanted or a doctor advised them that they would want. We would not participate in that. And we make that very clear up front so that there's no confusion later on in case that issue came up. But we don't only just tell people that we won't do it, we also educate people as to why we won't do it. And most people are very receptive to that once they understand why. And that's something that's very important to us. The most important thing, if you look at the very bottom, that really separates AmeriCare from other hospices as a Catholic hospice, is our sacramental support. We believe your faith must be part of your death. If you think about that, what more important time should your faith be part of your life than when you are nearing that time when you're going to return to our Heavenly Father? It must be part of your death. Now, any hospice setting that you're in, whether it's Catholic or not, right now still under Medicare guidelines, they are required to help find you a chaplain if a family asks for that. If they ask, if you're Catholic, for example, get us a priest, they are required under Medicare guidelines right now that they have to find a priest for you and bring, or as quickly as possible, or a chaplain if they couldn't. We are much different than that. We go well above and beyond that. Your sacred support is part of your plan of care from the very beginning. Part of that entails, once a Catholic is admitted under our care, for example, I don't care if you went to Mass 10 days ago or 10 years ago. If it says that you're Catholic, we are immediately seeing what we can do to help support you in that sacred arena of what you might need. Whether that's sacraments for anointing, whether you need to go to confession, maybe you've been active in your parish but you can no longer go to Mass. I'll be contacting your parish to make sure they know that we're helping care for you. If you don't have communion being brought to you, I'm going to ask them if they can start having someone bring communion to you. Or in some cases, bring communion to a spouse who right now would be able to go to Mass, but is constantly at home helping care for their spouse, and so they're not able to make it. So sometimes we have that, where I'm calling a parish to have communion brought for the spouse because they're not able to make it to Mass. We have a prayer group that's constantly praying for our patients. Some of our patients or their families give us special intentions, so we're praying for them. We give our patients blessed sacramentals. They get blessed scapulars and handmade rosaries, small crucifixes, Chaplet of Divine Mercy and rosary pamphlets. We call that our sacred support bag. That is given to that patient and family the first time that our priest visits with them. That's another thing, is that we have a priest that is on staff. So that your chaplain, under Medicare guidelines, you're supposed to have a chaplain that's contacting you. For our Catholic patients, that's a priest that works for us that is doing those regular visits that are usually somewhere between 1 to 2 times a month. And then beyond that, if somebody is wanting more visits, then I help try to arrange that. We also have Catholic volunteers that we've tried to gather and continue to gather from all around the valley. And their purpose is to offer fellowship and prayer to our patients. We don't force this on our patients. You know, some people naturally at the end of their life are not going to want to start new relationships with someone, and that's okay. But a lot of people, they're very isolated and become very lonely when they can no longer go to church or part of the groups that they used to be part of. And the idea of having a fellow Catholic come by to pray with them, to tell them about Mass, maybe read readings, maybe just chit-chat with them, maybe once a week. Doesn't want anything from them, doesn't want to take their blood pressure, doesn't want to ask them any medical questions, just wants to sit and chat and just have a nice conversation from their community. That means a lot to so many of them. And so that is part of what we call our sacred space outreach. And just a little plug in case any of you are interested in that, we do regularly have orientations for new Catholic volunteers, and that will be next Wednesday on the 30th. And that will be at 9 a.m. at our offices that are just west of Stapley and Brown. So if you're interested in that, please make sure you come and see me afterward, and I can tell you how to let me know if you're coming. So we do try to have those regularly. And that, again, is to try and keep Catholics connected in their community. And on that note, you know, so many times if we were to not respect what we just read from the Catechism, if we weren't to respect that God alone decides when we're to take our last breath, and we did anything that would hasten someone's death, I can't tell you how many times I have been part of beautiful things at the end of someone's life. We have no idea what God is doing with each soul before they die. It's such a presumption for us to think that if someone is there and they're not responsive, that we think there's nothing left to do. We need to help end this, so to say, when we have no idea what's going on with that soul. And so many beautiful things have happened, so many beautiful experiences, that it's just, we can't express enough that really, truly at AmeriCare, we try to respect that God alone knows when that soul is to leave this world. And we've seen many seeds planted in family members who have been away from their faith, in those patients who have had that opportunity for the sacraments and reconciliation and to return to their faith at the end of their life. We've seen a lot of healing, a lot of beautiful deaths that otherwise may not have been possible. And if you think about that, under Medicare, I try to explain sometimes to people, some people will say, well, any hospice has to get you a priest if you want one. But sometimes I've asked people to think, if you've been away from the church for countless years for whatever reason, how many of those people do you think are going to say, you know, I've been a really bad Catholic, I've been away from the church, I've been to confession, and I can't even tell you how long. Would you mind trying to find a priest that would come talk to me? Many people will never ask for that, either because they're ashamed, they're afraid. But a Catholic walks in, I've done it many times, just a fellow Catholic, nothing that special about me, but I've walked in and talked to them, and just having a fellow Catholic talk to them, and then at the end offer that to them. You know, would you like to see a priest? I could, you know, anytime you'd like, we could have one come and see you, and you could make a confession, start receiving communion again. So often they're like, okay, just because someone offered that to them, but it's not something they necessarily would have asked for and had to try and keep asking someone if they would find that out for them. So again, a very beautiful experience where we can allow people to be open to everything that they have available to them sacramentally with the church, which is something that truly separates us from other hospices. So how do you choose it? Most people do not understand that you have a right as a consumer, as a human being, to decide who provides hospice care for you or your loved one. If you are in a hospital or a doctor's office, we are not going to be able to come in and say, hey, we saw that you're a Catholic, and did you know that there's a Catholic hospice, and we would love to talk to you about if you would like to choose us. It doesn't work that way. We have to be invited in. You have to say, I would like to have AmeriCare provide my care, or I'd like to interview 3 hospices before I make a decision. And that's very difficult, because if families have not talked about that, or you haven't researched it or decided ahead of time, you may find yourself in a hospital, and those doctors and hospitals will naturally funnel you in the direction of a hospice that they are connected with. That's where a lot of the misnomer of, oh, I just signed on for hospice, and then somebody came in, said sign this paperwork, and it was done. And then they didn't realize that they have a choice of who will provide that to them. So it's really important. We do have some things back on the table. One of the most popular and really convenient things that we're offering right now are these hard cards that look like a Medicare or insurance card or credit card. On the back it says, I have pre-selected AmeriCare Hospice for my hospice needs. A lot of people are now carrying cards like this, either for home health or hospice care, so that if you had to go into a hospital and they say, give us all your insurance and medical cards, this would go with that little stack of cards, and this would tell them this is who they've already decided they want called if that's necessary. So that if there isn't someone there to tell them and they just send their own person in, that's their contact, they would already know, nope, we're supposed to call this place and have them come in and do that. Also, anytime, whether you need hospice care or not, or you're not quite sure for a loved one, myself or someone else from AmeriCare will always come out free of charge, meet you at church, meet you anywhere. Some people have met over coffee, on the phone. I've talked to many people. If you have any questions, just to be more informed, or think maybe you might be in a situation in your family where it might be time to start thinking about it, but you're not quite sure it's time to sign on, I have no problem, and anyone from AmeriCare will come out and talk with you and let you know, and then try to help you make a good decision, or say, you know, when this or this happens, and give us a call back and we'll come out. I do also have people that have loved ones that are under another hospice agency's care, and as practicing Catholics, they may have concerns about things that they're being advised to do or things that are being done. I'm always available to answer questions about that too. If somebody calls, please don't feel like if they're not being cared for by AmeriCare, I won't help you. So you can always call, and that has brought a lot of relief to some people. There are many different family dynamics. Sometimes families disagree about the best decisions for their loved one, and if that happens to be the case and you're concerned and what can I do, what can I look for, please feel free to give me a call as well. So if you are in that situation, just know, and we advise people to do research, to interview a few hospices, and to know, most importantly, that it is your choice of who will provide that care to you. On the back also afterward, we also have a number of things besides these cards. Got free stuff, free pens, sticky notes, magnets, that good stuff. And then our brochures. This is our most popular brochure card, and for those that don't want to read as much, and then this is our other brochure. Please feel free to take as many as you like. I always have extra too, so sometimes we do have people that are in the healthcare field or connected to some community and they'd like to take some. Please let me know, and if by chance I didn't have enough, I'll get them to you. The most important thing is we just want to help people know about that we are out there and how we might be a little bit different in terms of being a Catholic hospice.
Tonight, basically, I'm going to try to address the issues that come about in the medical situation for the terminally ill patient. Talk about so-called ordinary and extraordinary means, stopping and starting these machines that we all know about. Who makes these decisions? How are these decisions made? And what about advanced medical directives? What are they? We'll touch on that a little bit at the end also. On the slide here is indicated the website for National Catholic Bioethics Center. It's www.ncbcenter.org. And I bring that to your attention for two reasons. Number one, that's where I received my certification for medical ethics, and that's where my material will come from. And also, it's a great website for anybody who has basic questions around medical ethics situations. You can go there and you can peruse that website and find all kinds of information. If you happen to get to a point where they tell you you need a password, just give me a call or drop me an email and I'll get that information for you, because I do have a password. You know, when I graduated from Creighton University Medical School in 1965, things were very, very different. There was no organ transplant service at that time. Usually people, when they had a heart attack, died. There was no angioplasty, there was no stents. Coronary bypass surgery was really, really infantile. I can remember working in the animal lab with the cardiovascular surgeons when they were first starting to work on bypass procedures. When your knee or shoulder or ankle gave out and you got arthritis in it, you just learned to live with the pain and you learned how to limp. And you know, guys, back in those days, when your get up and go got up and went, it was gone. There was no Viagra in those days. It was just gone. When I finished medical school, when I finished my residency in radiology, there was no ultrasound, there was no CT, there was no MR. Nuclear medicine was very, very much in its infantile development, and its angiography was also. Now, can you think about going into a hospital today and not having those procedures available for you? It's not heard of. I mentioned this for two reasons. Number one, medicine, in my experience, has advanced exponentially, and for good reasons, for good causes. But those good reasons and good causes have also brought about some questions, both morally and physically. Questions about cardiac support devices, ventilators, tube feedings, hemodialysis, chemotherapy, and all of these things. So the major question that I think we want to address tonight is, must all that is medically available be employed in the treatment of a patient with a terminal illness? Now remember, we're talking about death and dying, we're talking about a terminal illness. Or are there guidelines that we can use to stop some of these treatments, or maybe not even to enter into them? Is there a time when we can pull the plug on a machine, if you will, that's morally licit and morally reasonable? You know, as I meet and discuss end-of-life issues with people, I find that most people aren't upset with the idea of dying. Most everybody's accepted the idea that we're going to die. Some of us even look forward to that time, because when I die, then I move on to a better life. What people are concerned about, among other things, or most concerned about, is how they're going to die. It's the dying process that has got people's concern. And I just want you to know that Catholic Christian teaching and healthcare ethics provides guidelines for treatment of all phases. These are primarily found in a document called the Ethical and Religious Directives for Healthcare Facilities. And I guess I don't know where it's at. It's here someplace. But it's a small document, has something like 77 directives in it. And it's what we use to address these questions from a medical ethics point of view, called the ERDs for short. In 1971, the National Catholic Bishops' Conference created what they called a Committee on Doctrine. Now think about it, 1971, that's when the birth control pill was flourishing. That's when all kinds of breakdowns in moral behavior were commencing in our society. And the bishops recognized this and realized that they had to start to formulate some directives, and that's where the ERDs were born. The purpose of the ethical and religious directives are twofold. First, to reaffirm the ethical standards of behavior in healthcare that flow from the Catholic Church's teaching about the dignity of the human person. The dignity of the human person underlines everything that the ERDs talk about, have to say, and guide us in. And secondly, the ERDs are there to provide us an authoritative voice when it comes to moral issues that face us in questions around Catholic health care today. You know, when Catholic medicine began, it began with the good sisters in the hospitals. There's something like 659 Catholic hospitals in the United States. I think that's an astronomical number. The highest, the largest group of hospitals, regardless of whether it's federal, state, religious, or whatever, are our Catholic hospitals. But today, a lot of the religious communities aren't there anymore to guide these, and lay Catholics have taken on an increasingly important role in these ministries. Catholic health care expresses the healing ministry of Christ. This is the essence of what the ERDs are about. And in a specific way, they deal through the local church relative to these issues. And the local church is guided by our bishop, as our bishop exercises these responsibilities in his role as pastor, teacher, and priest. As pastor, the bishop has the opportunity to encourage the faithful to take on a greater responsibility in accepting the Catholic ethical standards around medical care. It's easy in our society to just go and do all kinds of things, but to really practice in a Catholic institution in a Catholic way is a more difficult thing. And it's our bishop's role as pastor to encourage us in that way. As teacher, he encourages us and ensures that the moral and religious identity of our Catholic institutions are there. And as priest, he ensures us that the sacraments, the sacramentals are there. And as Bobi pointed out, that is the key thing, for me anyway, working with America Hospice, that separates it from the others. I have seen this in action. I have seen the sacraments and the sacramentals be highlighted to the patients under their care. And it's a beautiful, beautiful thing that is necessary for our dying Catholic people. Now, while the church can't furnish a ready answer to every moral, ethical question that might come up, there are many questions that it can. And she provides this guidance and this direction through the ERDs. And in the absence of a direct response from the ERDs, we have the magisterium of the church that never puts out any kind of information that is contrary to church teaching, that is also an author of guidance around these issues. So I just wanted to make this point because it's important to understand that what we're talking about from the National Catholic Bioethics Center isn't just something that's been pulled out of the sky. This is something that is a part of the universal church and certainly a part of our National Catholic Bishop's work. The section of the ERDs that we deal with in end-of-life care is section number 5. Now, all of the ERDs are set up in the same way. There's an introduction to the ERDs, and then there are the directives themselves. Excuse me. The introduction basically talks about the theological background and the theological basis for the directives that we are going to address. I don't have time tonight to go into a long dissertation about the ERDs, but I would just like to pinpoint a couple of issues, and we'll talk about The first ERD, which is number 55. In this directive, we are told that Catholic healthcare institutions must or should provide all patients with appropriate opportunities to prepare for death. We have to give our people an opportunity to prepare for the Christian death. The Christian death has to be something that we don't shy away from. It has to be something that we don't hide from. It has to be something that we acknowledge and that we present to the patient as the next step into the eternal life. Persons in danger of death should be provided with whatever information is necessary so that they understand their condition. They understand their prognosis. They understand that what will happen if this course of therapy is given, does it go that way? If this course of therapy is given, is it going to go that way? They need to know what their prognosis is, and they need to have this very clearly spelled out for them. They need information also to address the morality of legitimate choices that are provided to them. And finally, and most important, I think, they should be provided with spiritual support as well as the opportunity to receive the sacraments in order to prepare well for death. So this is not just a local dream that people in America have come up with. This is a directive from the bishop's offices. This is a directive from the ERDs telling us that we need to provide sacraments and sacramentals to the dying person. Ordinary care and extraordinary care are two major components to the ERDs, and I'm just going to comment briefly on this by giving a definition of what this means. Ordinary care, ordinary treatment, ordinary considerations are those that in the judgment of the patient offers a reasonable hope of benefit and does not entail excessive burden or impose excessive expense on the family or on the community. We'll talk about that a little bit more in a minute. And extraordinary care are those that, in the patient's judgment, do not offer reasonable hope or benefit, or may entail an excessive burden or impose excessive expense on the family and on the community. These are right out of the ethical and religious directives, and we'll go into that a little bit more in a minute also. Now, as human beings, we tend to shy away from pain. We don't like to suffer. We don't like any kind of discomfort. It's something that we recoil from. I made a comment this morning that back in September, October, I was called, I was among all of the people at the hospital were told that we needed to go and get the flu shots. And I said, I'm not going to get the flu shot. I don't need that thing. I'm not going to get stuck again by that nurse. And besides, I have to wait for 15, 20 minutes in the ER. So I need to get the flu shot. And for the last 3 weeks, I've had the most god-awful sinus infection that I've ever had in my life. Now, I can say that knowing full well that several of my colleagues at the hospital who did get the flu shot have an equally bad sinus infection and sinus problems, so it's not just that. But suffice it to say, as a people, we try to shy away from pain. How we decide to respond to suffering is one of the most important human choices we make. For many people in our society, suffering is sort of like a singular evil. It's something that needs to be avoided at all costs, no matter what. So we approach our pain and suffering in some unreasonable ways. We have a relational problem maybe, and we turn to drugs or alcohol. We suffer through a pregnancy that maybe wasn't planned, and the thoughts around abortion come about. We have a disease process that is going to be terminal, and instead of going through the whole process in a way that is spiritually oriented. We choose physician-assisted suicide. These are all difficult decisions that have to be made, and we have to be able to understand that the Christian understanding of suffering, what that really means. In medicine, we have to be careful to let our patients realize that their suffering has a meaning. Too often, I'll have a patient to study who has just given up. They've given up because they feel like they've become a burden to their family, or they're useless. They can't do the things that they used to do. The question of suffering arises on a regular basis. The ERDs remind us that patients experiencing suffering that cannot be alleviated should be helped to appreciate the Christian understanding of redemptive suffering. Now, each of us, as we grew up, I would bet, have had a time where we skinned our knee, or we stubbed our toe, or we sprained our wrist, or we fell on hit our head, or we have a headache. And we come to mom and tell her what's going on. And what was the first words out of her mouth? Offer it up. Now, you know, I joke about it, but I've tried to bring the idea about redemptive suffering to all the groups that I talk to, and that's not an easy thing to do to a Protestant group. That's not a concept that they really could grasp. But from the time we were very small until now, we've been told to offer it up. Those three famous words. They simply are words to remind us how our suffering can benefit not only ourselves, but others around us in this mystery that we call the human communion that is in and around us. So, moving on. We mentioned ordinary and extraordinary care a little minute ago, and I just want to break that open a little bit more right now. Because the first component of that definition says that in the judgment of the patient, it's the patient who decides these things about the treatment. It's not Uncle Charlie who lives in San Diego that you haven't seen for 6.5 years, and all of a sudden, because he hears that Aunt Molly is dying, rolls into town to try to tell everybody what should be going on. Or it's not the loving wife who has been there with the patient through 55 years of marriage. It's the patient. It's the patient who makes this decision. The decision has to be based on whether or not this treatment or this procedure offers a reasonable hope of benefit. Now, except for surgeons, there's not many physicians that will tell you absolutely what's going to happen. Surgeons always know absolutely what's going to happen, but the rest of us, we have a little wiggle room that we have to use. But we can tell you pretty well what is going to happen so that we can give you a reasonable hope of benefit for this procedure, or we can tell you that this procedure is not necessarily, we're not sure what it's going to do. But you need to know that kind of information. And then the next part about this decision making is, does this procedure entail excessive burdens or impose excessive expenses on the community and on the family? What are these burdens? What do we mean by excessive burdens? First and foremost, some of these procedures can become so complex and so costly that they become a burden to the patient. Think about the patient on renal dialysis. And I use this because it's a fairly common example of somebody with a terminal disease. Somebody who has renal failure, their kidneys have crumped, they're not working anymore, has to go on dialysis. If that patient isn't continued on dialysis, that patient's going to die. Now, that patient may have to go onto dialysis every other day for 6 or 8 hours. Go to this dialysis center, to this building, get hooked up to this machine, sit in this extraordinary chair for 6 to 8 hours every other day. Maybe not every other day, maybe 3 times a week. But as time goes on, this can become burdensome to that patient. It can get to the point where psychologically and spiritually he just says no more. And he has the right to say that. He has the right to say that. How does the patient feel about the requirements for a specific treatment? Are there cultural issues that come into play? Some of our Native American community have some specific cultural issues that come into play when it comes to some of the treatments that are to be offered. Again, is this treatment going to improve the condition? Is it going to improve my condition? If you don't remember anything else that I say tonight, hopefully you'll remember two things. When you're presented with a treatment option, you have two definite questions that you need to know the answer to. Number one, is that treatment going to help me? Am I going to benefit by that treatment? If not, are there alternatives to that? And the second thing is, that's the second thing. The first question is, how is that going to help me? And the second thing is, if it's not, are there alternatives to that form of treatment? You have the right and you have the need to ask those questions of any kind, anytime a question arises around these issues. The other thing is, sometimes these treatments can be some loathsome to the person. I have a good friend whose father passed away not too long ago. I saw them in the hospital. I was just passing through. Went up to see the guy, and he had Parkinson's disease. And as part of his Parkinson's disease, he was aspirating. His food wasn't going into his stomach; it was going into his lungs, and he was having continual recurrent pneumonias. And they were getting worse and worse and worse. So the treatment option that they offered him was to put a gastrostomy tube in. To put a gastrostomy tube in, you stick a tube down the throat, into the stomach that's got a light on it. You stick it out to the side wall, push it hard against the side wall so you can see the light coming through. And then you take this trocar, which is just a big old sticker, put it into the abdomen, then you feed a tube over the top of that and leave that in, and you use that to feed the patient. It's a simple procedure. I've done many of them. But this guy looked at that and didn't want to have any part of that. He didn't want to have any, to him that was just totally unacceptable to have that tube coming out of his side into his stomach and to be fed that way. He didn't want to not be able to eat. And when you think about it, eating has all kinds of psychological and spiritual components to it. From the taste of the food, the smell of the food, the texture of the food, that whole idea around eating becomes very, very important. He did not want that tube, and he had the right to pass on that. At that point, that tube became an extraordinary means of treatment for him. The burdens that are presented to the patient simply must not be greater than the perceived benefit from whatever the treatment is going to be. Treatment that is excessively burdensome to the patient is extraordinary and does not have to be accepted. Let me read to you directly from the ERDs, from ERD number 32. It says the following: if medical treatment is unacceptable to the patient when all relevant circumstances are taken into consideration, that treatment is no longer ordinary or proportionate. And that's the statement in there that's key, is when all relevant circumstances have been taken into consideration. Now, I just bristle when I hear people say, well, I've got a living will, and I put in my living will, I don't want to ever be hooked up to a machine, and I don't ever want to have a tube put in me. That's stupid. That's absolutely stupid, because sometimes being hooked up to a machine for a short period of time is absolutely necessary to take a patient from an acute situation over the hump to where they can recover. Sometimes patients come in, I'm seeing patients in the hospital with pneumonias where both lungs are filled up with crap. And if those people weren't on a respirator for a week or 2 or 10 days, they would never be able to recover from that. So, they have to know that. They have to know all the circumstances. They have to know the prognosis. Informed consent is so important. If it is still unacceptable, knowing all those things, then it is no longer ordinary treatment. While every person is obliged to use ordinary means to preserve his or her life, no person should be obligated to submit to a healthcare procedure that, again, the person has judged with free and informed consent does not provide reasonable hope of benefit without imposing excessive risks and burdens on the patient or excessive expense on the family and community. Now that last one really gets some people. What is excessive expense on the family or on the community? I can't answer that tonight, but that is a consideration that people can justifiably look at. There are some times where the expense to the family has to become a relevant consideration and a relatively important. These are complex issues. These are not the kind of issues that just pop up every day and we work out very easily. And I just want to emphasize that not only are we blessed by Bishop Olmsted to have a Catholic hospice in the Valley, we're also blessed by him and his leadership in the medical field in a lot of ways. There are several of us, priests and deacons, who have been certified by the National Catholic Bioethics Center. There are several physicians who have been. We have Father John Eric at St. Thomas the Apostle Parish, who went off to Rome for 2 years to get his licensure in medical ethics, essentially. And so there's a lot of people around that can help to answer these questions when these questions arise. They don't have to be, they don't have to be handled in a vacuum by yourself. Question comes up here, Debbie's here, Father Charlie's here, I'm here, other priests and deacons are here. We have the resources here at church to help you work through these problems. And one last quote from the Catholic Catechism, and please don't ask me what the number is because it was pointed out to me this morning that I forgot to put the number down. But the Catechism says that discontinuing medical procedures that are burdensome, dangerous, extraordinary, to the expected outcome can be legitimate. It is the refusal of overzealous treatment. Here, one does not will to cause death. One's inability to impede death is merely accepted. This is the next big issue that we have to talk about. Food and hydration. The removal of nutrition and hydration from patients who are incapacitated but not dying has become all too common in our society today. There's horror stories out there all over the place about this kind of thing. Often a patient who has suffered a stroke, for instance, or is otherwise unable to communicate, is said to have a poor quality of life or to have become burdensome. His life has become burdensome. Whenever I hear that, if I have the courage to address the person, I will say, burdensome to who? Who's his life burdensome to? Certainly not the patient who's had the stroke. Maybe it's become burdensome to the, quote, caregivers who would like to see Uncle Charlie go to heaven quicker than God wants Uncle Charlie to come to heaven. But that nonsensical thing about burdensome just bristles me. The Catholic Church teaches us that life has an inestimable good, even when it is affected by illness. It has the same value. The same value remains well or ill. In fact, if you think about it, Christ's mission of healing the sick and elderly people really deserve special care. Medical science is called on to eradicate illness from which we suffer. It is not called on to eradicate the person who is suffering. And that's what withdrawing food and hydration does. That's what we did to Terry Schiavo. Terry Schiavo didn't have a terminal illness. Terry Schiavo didn't die from her disease. Terry Schiavo died at the murderous hands of her husband. She was killed. She was starved. And that is something that we can never allow to happen. The teachings of the church on the provision of food and fluid aren't meant to be a burden. In fact, they're meant to express a genuine human concern for the dying patient. And let me just mention a few points around food and hydration. And the first thing is, let me just take a step back. I mentioned earlier that the ERDs were developed back in 1971. We're now in our 5th edition of the ERDs. The 5th edition came out 2 years ago. And the thing that brought about that change, the new edition, was a dictum from Pope John Paul II around food and hydration and its administration after the Terry Schiavo thing. And basically what our Holy Father said, and you will tell that I'm summarizing this because he never speaks this briefly, but he said we should provide food and water even by artificial means to all who are in need of them and can physiologically benefit from them. So everybody that's alive is in need of food and hydration. The key point there is who is physiologically able to benefit from them, and even by artificial means. The artificial means, again, are the nasogastric tube, the intravenous catheter, the vena cava catheter, G-tube. These are all extraordinary means, or these are all means that are no longer considered extraordinary, and they should be utilized if and when the patient can physiologically benefit from the administration of the food and fluids. Now, I just mentioned several different modes of administering these things. We should always use the one that is the least aggressive. And the least aggressive of all means of administering food and fluid to a dying patient is sitting there at the bedside with a spoon and a cup in your hand and feeding them. Feeding your loved one, feeding your family member, feeding your friend who is dying. That whole concept has been so lost in our society today. We immediately want to have a tube put in or something like that. And sitting there with the patient, administering little chips of ice, a little bit of water, they don't take a whole lot, but whatever it is they need and can consume is the best way to handle this for a lot of reasons. Number one, it brings about that community of the dying patient with his family. And number two, think about it. You get no satisfaction from food and fluids given through tubes and catheters. But again, when you're fed, you have the texture of the food, the smell of the food, the taste of the food, that whole psychological thing that goes along with eating that can really benefit the psychological, the spiritual well-being of the dying patient. And that's really what we're talking about. Patients should always receive food and water by mouth if at all possible. Now, the other thing about that we talked about is that if the patient is able to tolerate, we know in medicine when the dying process is started. It's got very definite physical signs and physical findings. So you know when the patient is going from a stage of imminent death to near death. And those phases are well thought out and well defined. Once the organ systems start to shut down, then there's no requirement any longer to continue to administer food and fluids. For instance, if somebody is dying of renal failure, they're not able to handle fluids, there's no sense giving them 3 liters of Ringers or dextrose and water or whatever you're giving them every day, because that's just going to do nothing more than fill up their lungs and you're just going to basically drown them. If somebody has a GI cancer or pancreas cancer or something that has affected their digestive tract, there's no sense putting more and more food in there, because that's just going to cause them to bloat up, to become nauseated, have diarrhea, and just make them physically more uncomfortable. The dying process can be made comfortable if we just give it a chance. Father Tad Petralchik, is the Director of Education at the National Catholic Bioethics Center, and he points out that basically we really have a problem with passive euthanasia, where we stop administering food and fluid to patients. This came about during the Terry Schiavo thing again, and Father was talking about some of the people in science and medicine will tell you that dying of dehydration and dying of starvation is really not that bad of a deal. It's not that hard. You don't really suffer that much. That's a bunch of hogwash. I bet you everybody in this room has had an opportunity to fast for a period of time. Now, think about the last time you were on a significant fast. Didn't you feel the hunger pains? Didn't you feel uncomfortable? Didn't you feel whatever you felt? Because those are primordial drives that we have. Thirst and appetite are something that every animal has. They're primal drives that just can't be taken away. There's intense pain, in fact, that comes from these things, as we have had reported by several patients who have recovered from a near-death experience, if you will. The one that I would like to relate to you here tonight is the story of a lady named Kate Adamson, who was said to be in a, quote, vegetative state. If that's not the worst concept or worst terminology that ever has come about in anything, I don't know what it is to call a human person a vegetative state. But anyway, that's what we're stuck with. Kate had a stroke, and she was considered to be in a vegetative state. And she had been in that condition for quite a while. She's 40 years old, living in Florida now, having recovered from that episode, and she's listening to the radio. And Terry Schiavo's husband's on the radio telling the radio person what's going to happen with Terry and that it's not that bad. She's really not going to suffer. And Kate went bonkers because she had her feeding tube withdrawn while she was in this state for about 8 days. And she remembered every second of it. She remembered the pain. She remembered the discomfort. She remembered lying there, unable to communicate, crying out in her own way, "Don't you know what you're doing to me? You're killing me. I need food. I need water." She was interviewed on Bill O'Reilly's program, and one of the things that she said towards the end of the thing was that once she was able to recover from this whole thing, she had a nightmare one time that they were going to give her Gatorade. And she absolutely hated Gatorade ever since. But suffice it to say that removing food and hydration from these people is a very, very difficult thing. A very difficult thing. So who decides about these treatments, these treatment options? Again, we try to point out that it's the patient and the patient with real informed consent. Full disclosure of the nature and prognosis, the likeliness of progression of the disease, open and honest discussion of the treatment plan, open and honest discussion of complications of the treatment plan and side effects are all very, very important in this decision making. Catholic teaching does not require a person to sustain life and to avoid death at all costs. There's nothing anywhere in church that says you must be hooked up to this, that, or the other machine and you must stay there forever and ever. Absolutely not. What is usually of greatest concern to the devout Catholic is whether a particular decision to withhold or withdraw life-prolonging treatment constitutes neglect if death follows. Did that come out okay? What people really worry about, and we get these calls, we get this calls, patient with a severe debilitating neurological procedure has come in and out of the hospital many, many times over the last 6 months with recurrent pneumonia. There's nothing that can be done medically for the neurological situation. The pneumonias are getting worse and worse. He's now on a ventilator, and the doctors are telling the family that the ventilator should be withdrawn because the ventilator is not doing anything except prolonging the obvious, and it's making him suffer more. But the poor wife, now she can understand the idea about not treating his pneumonias anymore. She's okay with that one. But to disconnect the respirator is something that she just can't put her arms around. We need to talk to those people. We need to pray with them. We need to counsel them. And that's where the Catholic hospice really comes into play. Because allowing death to come naturally, rather than fighting it aggressively with burdensome measures, is not neglect, but it's the serene Christian acceptance of death, something that we can't avoid. Finally, I would just like to make a few comments about this concept of advanced medical directives. But first of all, I want to call your attention to this document, and we have some back there for you to take home if you like. This is the Roman Catholic Diocese of Phoenix Advanced Medical Directive. It comes with a cover letter from Bishop Olmsted, and then an introduction that I think you'll find very informative. Because what we did when we put this together is we took the ERDs from Section 5 and we discussed them briefly, but we discussed them so that they are there and you are able to read the directives and to understand more what is going to be said towards the end when the directive comes about itself. There's also questions in here. What is a healthcare power of attorney? What is the most important aspect of a healthcare power of attorney? And if I am sick or dying, am I required to do blah, 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 blah. So I think if you take this home and look this over, you'll find this to be a very informative document, and it can function as your advanced medical directive. It is not a living will. And I will tell you, and you can quote me to whoever cares, the living will ain't worth the piece of paper it's written on. Because unless you know exactly how you're going to die, unless you know exactly what disease you're going to get today that's going to be terminal for you, a living will can't cover anything. Deacon Abe said that I should quit saying this, but I'm going to say it. I don't know whether I'm going to die of pancreatic cancer or get shot by a jealous husband. I just don't know. And I don't know why Abe had problems with that. But unless you know those things, the idea of a living will really is meaningless. Living will is like taking a sledgehammer to try to line up a broken leg. It might help sometimes, but it's really a very, very blunt instrument, if you will, because it just cuts across all kinds of things. And in fact, A lot of the living wills have a statement in there that you need to be aware of, and if you have a living will, I would suggest you dump it, but if you're going to keep it, you need to be aware of and look at it and see, because there's a statement in most living wills that says, if I become mentally incapacitated, I direct that food and fluids be stopped. Well, I think I've said enough already that you can understand why that's inappropriate. Plus, if you talk to my wife, she'll tell you that I'm mentally incompetent half the time. So, I mean, it's just a nonsensical statement. Father Tad talks about a person that brought in his living will. He wanted Father Tad to read through his living will to see what he thought about it. It was 564 pages long, because this guy sat down and looked at every possibility under the sun that he could die from. That's what you would need to do to have a functioning living will. We have a much better document and a much better way of approaching this with the advanced medical directive that calls us to a power of medical, to the proxy for medical care decisions. The advanced care power of the Arizona Health Care Power of Attorney. It's simple, it's straightforward, and it's honest. What you're asked to do is you're asked to identify the person who is going to make these decisions for you. Now there's durable power of attorney up there. That's the kind of guy that if I'm incapacitated, I'm going to say he can write checks for me, he can pay my bills, he can do this kind of thing. That's for lawyers and for another discussion. But the healthcare proxy, the healthcare power of attorney, is the thing that this document is all about. The beauty of it is you should be using this now. You should be executing this now. You should be sitting down with your loved ones now while you're healthy and identifying what it is you would like to have done and not done. And just so you know, my wife is not my proxy. I wouldn't put that on Janice. And those of you who know her can understand that. I mean, it would not be fair to her to do that. Now, that may not be true of you and your spouse, but for Janice, it would be very difficult for her. My health care proxy stands about that high. She's about this wide, both ways. She's a Catholic nun in Omaha, Nebraska, who's my blood sister. Sister Midge will not let anything happen to me that she knows I wouldn't want to have happened. And we grew up, we're not 18 months apart. We have never disagreed on anything except who's smarter than the other. That's the only thing. And she don't want to accept the fact that I tell her she's smarter than I am. But enough. I've talked enough. This is back there on the table. I encourage you to pick one up, take it home, read it, and if you want to execute it, execute it. If you already have a living will, you can delete that, and you can, or a power of attorney, you can delete that and use this one. It does not have to be notarized. It can be notarized. There's a place back here to notarize it, but if you read through this, it's not absolutely required. If you feel better notarizing it, so be it. So thank you very much for your attention. We ask Debbie Parmenter to come up.
All right, good evening, everyone. I know the time is getting late, so I'm just going to talk pretty briefly about this. Everything is talking about the dignity of life, and I'm going to talk to you about once life ends and funeral planning. And I'm not going to go into the nuts and bolts of this is what we're going to plan for readings and the mass of that. That's something to do once the time comes. Or you can pre-plan your funerals. And I can tell you that I'm sure loved ones would love that if you would do that. It may seem morbid, but it takes a lot of the chores off of them. Again, letting people know ahead of time what your wishes are, especially if you have family members who may or may not be Catholic. Let them know what your wishes are as Catholics, because as Catholics, we treat even the burial of the body and how the body is treated after death very, very seriously and very differently than a lot of the other Christian religions out there. So I'm sure most of you, maybe not all of you, have had some sort of experience either planning or a part of a funeral at some point in your life. The time after a loved one dies is like riding an emotional roller coaster, I say. One moment you can be, floodgates are flowing and you can't stop crying. And then another moment you think, I am the most insensitive person in the world because I'm not crying. It's just, you're all over the board. But I want you to think of planning your funeral for your loved one as a celebration. And that seems odd. Yes, we're sad because we can't see that person, but celebrate them because they have moved on. God never intended for us to live on this earth forever. He wants us to be with Him. So think about it. They've moved on. They've moved on to that next step. And then hopefully they're now celebrating at the eternal banquet with Him forever. Isn't that our ultimate goal for all of us, is to be there with Him? So try and think about that when you're planning your funeral. And think about it as a celebration of the life that we had with Him here on earth, but a celebration of that eternal life that they are enjoying now and that we hope to be with Him at some point. So I want to quote from the Catechism. And I did mark the paragraph. It's 1680. I have to bring that up after this morning because Joan specifically asked for the reference and I actually put it down. So, all the sacraments, and principally those of Christian initiation, have as their goal the last Passover of the child of God, which, through death, leads him into the life of the kingdom. Then what he confessed in faith and hope will be fulfilled. I look for the resurrection of the dead and the life of the world to come. And that's paragraph 1680. It is only through death that we can have this eternal life. We have to die. And our time here on earth, as I said, was never supposed to be permanent. So let's rejoice for our loved ones during this time. And so I kind of want to tell you with regards to Catholic Christian funeral, the rite of Christian funerals. There are, first, let me step back, who is eligible for a Catholic funeral? Most people, obviously baptized Catholics. That's kind of a no-brainer. Catechumens, those who are in process of becoming Catholic, are eligible for a Catholic funeral. And children who are unbaptized, but it was their parents' intention to have them baptized, but maybe it was a sudden death and they did not get the opportunity to baptize their child. They are also eligible for Catholic funerals. There are three major components to a funeral. There's the vigil, a lot of people heard called wakes, which typically happens between the time of death and the time of the funeral mass, in between that time frame. Most of the time, it's the night before. It can take place in the deceased person's home. That doesn't happen a lot of times these days. Typically, it's funeral homes, or it can happen in your parish church. We don't normally have them here at St. Tim's, but we have in the past. Most of the time that happens when it's a very large funeral and a funeral home just cannot accommodate the numbers that would be there. An example would be Angela Faddis, if you were a part of that. We had 400 or 500 people there for her vigil and her mass. So that does happen. It can be officiated by a priest, a deacon, or a layperson. The vigil itself includes scripture readings, songs, psalms, intercessory prayer, and a brief homily and reflection. Devotional prayers like the rosary are a part of it, but shouldn't necessarily take the place of it. And so a lot of people just say, oh, I just want a rosary. That's nice to be a part of the vigil, but to be truly complete and have a full fullness of the rite of the Christian funeral, to have that scriptural service done as well. And it is the preferred time for eulogies, which is the common term that you always hear people say, for family and friends to come up and reflect about the deceased one. The Mass is not the time for that. And so that's typically what people do, and that's when you should have those. The second and the central liturgical celebration for the deceased is the funeral mass. It is typically celebrated on the day of the burial or the committal. It must take place in a church. So if you think, oh, I'm just going to do everything at the mortuary, you cannot have a mass at the mortuary, just so you know. This is pretty obvious. The priest is the only one who can preside over the mass. The funeral mass itself is the same as every other mass with a few additions. It starts at the back of the church if we have a casket present. The casket is sprinkled with holy water, and a white garment called a pall is placed over the casket. Those are symbols taken from your baptism. Then the casket is processed in to the front of the church, right in front of the Paschal candle, which is lit. The Paschal candle also symbolizes our baptism. It is lit twice in your life. It is lit at your baptism and at your funeral, and it's the symbol of Christ's light to us. And then the only other change really is after communion, the final commendation, which takes place, which basically is our prayer entrusting the deceased one to God's care at that point. Prior to that happening at the end of Mass and after communion, at the discretion of the clergy, a single family member or a friend, somebody of the family's choosing, can come up and give a reflection about the deceased. But it should be brief and it should be Mass appropriate. It is not the time to talk about grandma going out and gambling at the casino necessarily all the time, or grandma really liked her, shot of whiskey every Friday night, which is fine, but not in the context of a Mass. But it's great to talk about I always like to tell the family, and I've seen some absolutely beautiful ones, talking about this person's faith life, to let those who are not there. I always like to see funerals or places, times and people's lives where it can either turn you away from Christ, religion, or it can draw you back in. I've seen many times where families who, for whatever reason, just stop coming to church. And it may not have even been an event that they are upset with the church. It could just be, we got out of the habit. We got lazy or tired on Sunday morning. And their son passed away before them. And they said, you know what? We really need to get back to church. So I really take that time seriously. Because it's a raw time and you really want to be as pastoral with people as you can. And then during that time as well, incense is used. The Catholic faith has wonderful symbols that we use. And incense, I know a lot of people do not like it, especially around here over the last time. But the incense during this is, it's actually a symbol of a couple things. It is, it's a time to honor the deceased, which through our baptism, we became a temple of the Holy Spirit. And so it's meant to honor them. It's also used as a sign of sending the community's prayers for the deceased rising up to the throne. So that smoke is rising up to heaven. That's also a lot of times the priests will say this during the Mass. Afterwards, the Mass is typically not ended until the burial. So what is liturgically correct at the end of Mass, the priest or the deacon will say, please let us take our brother or sister to their final place of rest. They don't typically end with a final blessing. That happens at the committal, which is kind of a little, people may wonder, well, Mass didn't really end. They forgot to do the final blessing. No, it's supposed to be at the burial. The third final thing is the burial and committal. And that happens as soon as possible after Mass. And the only time where you might have a delay is typically if we have cremated remains, and I will talk about that in just a minute. It can be officiated by a priest, deacon, or a lay person. Typically here we send deacons. And it is a brief little service, but again, has a short scriptural verse, prayer of committal, intercessions, and Our Father, and a blessing. The one thing, and you also, those who are there can leave A lot of times flour will be tossed on top of the grave, or sprinkling of a little bit of dirt. Those kinds of things also happen. Catholics who choose to be buried in non-Catholic cemeteries, you don't have to be in a Catholic cemetery. The requirement is that you are buried in blessed ground. A lot of times, if a deacon doesn't know that, whoever the person is presiding over that, they can do a short ritual of blessing of that ground if it happens to be in a non-Catholic cemetery. And so that can take place right as part of the whole committal process, if it hasn't previously been blessed. What I want to finally touch on here, which I think is a really big issue right now and a lot of misnomers going on, is Catholics and cremation. What is the Catholic teaching? The Church earnestly recommends that the pious custom of burial be retained, but it does not forbid cremation unless this is chosen for reasons which are contrary to Christian teaching. The Church prefers burial, which expresses more clearly the faith in the resurrection and the dignity of the body. And that's really been a central theme. Dignity of the body. We want to treat the body with dignity, no matter if it's cremated remains or left in its natural state in a casket. That's taken directly from our canon law. The most often misunderstood thought on cremation with regards to the Catholic beliefs and teaching is that the cremated remains of the body must be buried. All of them must be buried. You must keep them together. They must be buried in a cemetery, blessed ground, or entombed in a columbarium, in niches, those kinds of things that are part of the cemeteries. And they can be buried at sea, not sprinkled at sea, which is kind of a confusion. They think, oh, well, I can spread them out at sea. No, you can bury the entire thing at sea, but you can't sprinkle the ashes at sea. So, and the Church calls for the cremated remains to be buried without undue delay. They understand there are circumstances where you may have a family plot back in Kansas and they need to be transported there. The Church never intended for mom and dad to sit on a shelf forever in the living room. I think people, and I use this term and it may be blunt, would you keep a casket next to the couch forever? No. No one would think to keep grandma in the casket sitting next to you with a plant on top of it. I mean, you just wouldn't do that. That would just be rude. So you have to think of the cremated remains, that urn is the same as a casket. The whole idea, and there have been people with mortuaries, and in our diocese we do have Catholic mortuaries, Queen of Heaven down the road. You don't have to go to a Catholic mortuary, but there are mortuaries out there that give their people little mini urns. Someone here at the church was not aware that when her parents passed away, each kid was given a little mini urn with part of it. She was devastated when she found this out because she didn't know. A lot of people don't know. Maybe most of mom was buried, but not all of mom. And again, would you? Or they'll give you a little pendant with a little bit of ashes. Again, to be blunt, would you keep a finger wrapped around your neck and carried around? No. So think of that in those terms. One thing I know that's new that I had not seen, but somebody found out that there are mortuaries out there, and it may be worth asking. If you're dying, you just want to have that moment, you want that person, you want mom or dad or your spouse to be close to you, they make little pendants that have the thumbprint or fingerprint of that person on them. So it's just in metal, but I have my dad's thumbprint. It's his fingerprint, and I keep it right here. It's another way of having you there, but you're still respecting the dignity of the body and maintaining that dignity. And that's the key phrase, dignity of the body for that. And so, if you choose cremation, that's okay. There are 3 different options that should be followed. The most recommended option is to have the full casket present for the funeral mass, and then do cremation after the mass, and then burial after that. So there could be, again, that delay because cremation has to happen and then you can set up to have the burial done. That's the preferred. The question is, what about the casket? I have to pay for a casket? No. Mortuaries will rent the casket for you for the Mass. It's done that. The second option is the body is cremated and then the cremated remains come and they are present at the Mass. If that is the case here, the only difference is that the cremated remains, at least here, are not processed in. Other churches I've been to, they will process in with it. I am scared. I don't even want to carry them. I'm afraid that I will drop the person, and so they sit at the front, typically have a picture, but they are blessed with holy water, incensed most of the time. It's at the discretion of the priest, but typically all the same. Everything else is the same. It's a funeral mass. The least preferred method is to have the body cremated, buried, and then we do a mass. And at that point, it's no longer called a funeral mass. And there could be situations. We've had family members that I wasn't able to be at the funeral. And so we'll have memorial masses. If we don't have the body present, it's just called a memorial mass here. And we will do that for you. If the person was buried back there, maybe they did all of that there, but they didn't get to have that opportunity for whatever reason. Here at St. Tim's, we will do that. We will hold it. We would do a funeral, a memorial mass, but it's planned just as if it was a funeral mass. We just don't call it that because the body's not present. And the last thing I want to say with regards to burying the cremains is that Father Charlie is this is such a big thing for him, and that there are many reasons he's heard people, I can't afford a plot to bury this person. That if you have a family member that for whatever reason has never been buried, and you cannot do that, you are allowed to bring your family member here to the parish. We will document it, and until we have a plot that's established for which we can bury these cremated remains in, Queen of Heaven has offered to provide a secure place for us to store them. But we will take all the information down, we will document it if there isn't a plaque on it so we know whose remains these are. And then when the time comes that we are able to bury them, we will inform you and let you know. So that there isn't really any reason why you can't. That it's that important to him that he is going to offer this to his, to the parishioners. And it really doesn't even matter if they're Catholic or not. Just bring them in. And I had somebody call me when this kind of came out. He had a letter in the bulletin a while back about this, and a woman called me, and it was a very interesting story where 20 years ago, she and her husband befriended the neighbors next door, and these people who were not Catholic left in their will that they are to keep the cremated remains. And they've had them for 20 years, knowing that this isn't right, but they were a young couple. I can't afford to bury these people. They didn't give me the money to bury them at all. They just said, we give you the remains to hold. And so at this point, they're like, we really want to do right by these people. And so again, bring them in, we'll take care of it.